And good afternoon, everyone. A warm welcome this Saturday afternoon here at Sessions. We're excited to present this panel on self-monitoring for blood pressure as part of the Center for Health Technology and Innovation. I'm Bimal Shah. I am the Chief Medical Officer at Teladoc Health, and I'll be moderating today's esteemed panel. And we'll get the panel started off this afternoon with some brief introductions from our panelists. And then we'll start with a series of questions that I'll pose to the panel. And we really look forward to you in the audience utilizing the chat feature to ask questions of our panelists. And Neil Shah and I will be monitoring those and asking in some sort of sequence those questions back to our panelists. So once again, thanks so much for joining us. And let me start with having Rob Sanchez give us his brief intro.
Sure. Thanks, Dr. Shah. Welcome, everybody, and thank you for taking the time on a Saturday afternoon to join us. Really excited to have this conversation with everybody and glad to meet everybody here online. My name is Rob Sanchez. I'm the Chief Operating Officer at Tupelo Life Digital Therapeutics. Tupelo Life focuses on providing software, hardware, and services to providers, practitioners to help manage patients with chronic conditions at home. So we've been in this field and working with the American Heart Association for an extended period of time as we're part of the Innovators Network within the Center for Health Technology and Innovation. So I'm excited to be part of this. Thank you.
Thanks so much, Rob. Annie Lorenzo.
Thank you. Good afternoon, everyone. Thank you so much for attending this session. Very excited and honored to be here. My name is Annie Lorenzo. I'm our SVP of Business Development and Operations at Higi. And I run our subsidiary Higi Health, which is our 50-state clinical network and covered entity focusing on remote patient monitoring, helping providers and consumers. Just a little bit of background quickly about Higi. We started in 2012. We have 10,000 smart health stations in various community setting and retail locations. We have a very close partnership with the American Heart Association, where our goal is to capture health risk at scale and digitally enable individuals to understand their biometrics, and then really expanded that to the home with what we're doing today with remote patient monitoring.
Thanks, Annie. Next up, Art Lopez.
Great. Thanks, Dr. Shah. Great to meet everyone. Good afternoon and honored to be here. Art Lopez, VP of Business Development and Partnerships at Find Help, formerly known as Ambertha. Quick background on myself, spent the last 17 plus years in the healthcare space, working with large providers, payers, and large self-insured employers, last few years in the social care space. Quick background on Find Help. Again, formerly known as Ambertha. We just recently announced that. We are the largest nationwide social care network in the country, highly focused on making it easy for people to get connected to social care programs. So we work with over 400 plus organizations, major health systems, payers, FQHCs, cities, counties, school districts, and so forth, so that they can license a unique instance of the platform to both help their population self-navigate, get connected on those programs on their own, as well as support their staff as it relates to navigating on behalf of others. So really excited to join the panel today, and turn it back to Dr. Shah.
Thanks so much, Art. And last but not least, Farzan since Gohar.
Thank you, Dr. Shah. My name is Farzan Sasson Gohar. I'm an assistant professor in the Department of Industrial and Systems Engineering at Texas A&M. I'm wearing two hats. I'm also Division Chief for Health Systems Engineering at Houston Methodist Hospital. I'm a fellow of our Center for Remote Health Technologies and Systems at TAMU. They received a large NSF grant to build a engineering research center called PATS UP. Stands for Precise Advanced Technologies and Health Systems for Underserved Populations, where we do a lot of research around developing next generation revolutionary and cost-effective technologies at the point of care. Very happy to be here. Back to you, Dr. Shah.
Yeah, thanks so much, Farzan. Well, let me kick it off with, I don't think we could start any panel this day and age without actually talking about the past 20 months. And I think this is a great question to get us started on the panel. through the COVID-19 pandemic, we've certainly seen the rise in both the usage and the positive receptivity among patients and providers for remote monitoring solutions. What I'd love to hear from each one of the panelists is, what observations have been the most interesting for you, given the roles that you have currently, and what have you also likewise been most surprised in regards to the lack of that you were hoping to see, as we've seen the rise of certainly the interest in virtual and remote monitoring systems. And so I'll just start with Rob and go down our panel.
Yeah, sure. Thanks. So I guess some of the things that I've been surprised with was, of course, the uptick in remote patient monitoring and telehealth as a service. This is what the pandemic brought upon us, and many of us were already prepared to a certain extent to deal with that and address that and provide the tools necessary for patients at home. But it really lit the fire to do something about it right away. So for a long time, I think, like being in this industry for the last 10 plus years, it was always I had a lot of hospitals and practices that wanted to implement such a program, but putting it together always took a long time. And one of the things, the benefits and surprises that was really good to see was that things worked much faster at an accelerated pace. So that was a good thing. From a lack of, something that lacked out there, I think that ongoing follow through in terms of establishing the program and then seeing it through, I saw a little bit of that. And I think as providers are embracing it and adopting it, we're seeing that getting refined more and more as this technology gets better adopted at home as well by the patients.
Thanks, Rob, for those observations. Annie.
Thanks, Dr. Shaw. And Rob, echo what you said. I've spent my entire career in telehealth, working from larger companies like MD Live to startups. And for me, as horrible as this pandemic was, my father now knows what telemedicine is and to talk to his cardiologist, right? And so I think when you look at it from a patient or consumer perspective, we jumped 10 years is what I like to say in the telehealth industry, just in terms of everyone now knows it and we can expand broader from where we were, really trying to get the average consumer to engage with this wonderful technology and solution that's available. I think one of the other positive things that really came out of this was the changes in CMS, right? The ability to actually start reimbursing for preventative care in a way that makes sense and loosening some of those regulations, allowing broader providers to actually engage with their patients at home, really helped also bring this, especially the remote patient monitoring market, really to bear. From what I would love to see more of is I still think we forget about our seniors, right? I look at my dad and my grandpa, they're not super tech savvy. So when you have to download apps and do a bunch of different things, right, there's still kind of how do you get that elderly population up to speed and comfortable with using devices at home, understanding the data, and then connecting in more of a closed loop ecosystem with their various providers and their caregivers.
Thanks very much, Annie. Art.
Yeah, I mean, I certainly echo Rob's and Annie's comments. I think from our perspective, given that we're a social care network and platform, I think we knew when at the beginning of the pandemic that many folks out there were going to lean on our platform. So we did a few things to make it easier for people to get connected. We set up findhelp.org, which leveraged our full open public network, and we featured many of the COVID related programs, emergency programs, so people can easily identify those programs in their local communities. We work with many of our health system, CVO partners, FQHCs, to list a lot of the programs that they were standing up specifically for the pandemic. And then also, we certainly saw a huge uptick, certainly in the use of the platform. We went from right around the beginning of the pandemic from 25,000 referrals on a monthly basis, probably 400,000 to 500,000 connections to over 115,000 referrals in just a month right now, and over 1 million connections that we're seeing through the network. So a major uptick, and again, we were prepared and we knew that people were going to lean on us, so we leveraged the platform in a few of the ways that I just mentioned. So.
Thanks so much, Art. And then Farzan, you come from a little bit of a different angle than the rest of our panelists. So it'd be great to get that perspective from a large academic health system.
Of course, and I concur with all these comments. I think the pandemic resulted in this, forced adoption type of phenomena, where this was probably the only option at some periods of time during this pandemic. But as we're back to somewhat of a normal now, and patients are getting their options back, I think it's yet to be seen if these behaviors and these perceptions are sustainable. My observation is that providers are now much more willing to adopt these technologies because of these relaxed reimbursement requirements and conditions. On the other hand, we're still facing the same issues and challenges with patients who drop out, don't participate in these programs necessarily the way we expected them, which to me suggests that we still have a lot of work to do on the motivational and behavioral science of remote monitoring for patients specifically.
Yeah, some great points there, Farzan, and a lot of commonality in the themes that I think all of you guys are raising in terms of, certainly the rise that we saw across the board, but also some of the connectivity challenges that Annie mentioned as well that we still have to work through. And as we think about remote monitoring and self-monitoring, I think one of the key questions, certainly in physicians' mind and even patients' minds, is then how do you think about patients being seen monthly or every 3 months, for example, for their chronic conditions? Is that going to be a notional view that we can think differently about that? Is that still going to be the right cadence as we collect this ambient data from their homes? And so, Rob, let me start with you, and we'll shuffle up the order a little bit on this one to get our other panelists to chime in as well.
Yeah, sure. No, I mean, I think that's something that we've noticed at Tupelo Life. I mean, one of the things is having a structured program that is going to allow the patient to see their growth and trends, right? So with blood pressure control, just like with weight loss or even with diabetes, we've got to educate the patients to understand what their number means. And that's one of the things that we recognized in terms of how often you have to see these patients remotely. We really push for them to make it a habit to get to do their reading on a daily basis, capture that data, and then be able to provide the patient and the physician with appropriate trend lines on that patient. Because the flaw in only doing it once a month or only doing it when you actually go see your physician or your provider is that you're only getting maybe a couple of readings, right? Once every 3 months or whatever that cadence is. You're not going to get an understanding of how their lifestyle is impacting their rating. You're not going to get an indication of how their medication adherence is doing. So as we get to know the patient and their trends, we're also going to understand their lifestyle and are they taking their medication appropriately? Are they being consistent in taking it as directed? Maybe they need to adjust that. Maybe they need to take it in the morning before meals. Things like this do make an impact on the patient's trend lines. And by having consistent readings, we'll be able to share that data with the physician, thus being able to have that patient see those outcomes having an impact. And I think for that reason, it's important that we work with the providers to be consistent with the patient and taking their readings frequently.
That's great, Rob. And let's have Farzan, chime in, from the provider angle on what you just said as well, Rob.
Yeah, absolutely. I think benefits of an SMBP type of program are undeniable. I think we're going to have still a challenge to motivate both providers and patients to follow the new regimen. I think there are many opportunities right now in the areas of making these programs a little bit more effortless, including injectables, including context-aware wearable technologies, which is the main focus of our center, PATS Up. There's also a lot of areas of opportunities for digital coaching and persuasive reminders. So that's another very exciting area of opportunity we're exploring. And all these details of how frequently should we monitor, what time of the day, is more appropriate for providers to receive information, the type of presentation and mode of presentation. All these issues are very important. I'm going to have a shameless plug to my tomorrow's talk as part of, I believe it's Innovation Showcase panel, where I'm going to talk a little bit about the research in this area. But there's definitely a lot of opportunities to expand the foundational knowledge in this area.
Yeah, thanks, Farzan. Annie, I know this is something that Higgy has thought a lot about as well. Would you like to shed some of the commentary from your experience and Higgy's?
Absolutely. So I think if you look at where Higgy started as a company, we've done over 300 million tests or sessions across our stations, right? And we see 60% of those stations will indicate some sort of hypertensive risk or crisis. And so what we figured out pretty quickly was a good portion of our population is sick and may not understand what that means or what to do. And so when you look at layering on remote monitoring, I think we need to be a lot more focused in this country about managing preventative diseases. In 2019, we spent $3.8 trillion on health in our healthcare costs, and we had more hospital admissions for preventative diseases than other wealthy countries. So what that tells us is our model is really focused on sick care versus preventative care. So if you can actually start to motivate individuals to take their blood pressure from home on a frequent basis, but make it easy for those individuals. So our model, for example, we use cellular enabled devices, right? And we have a clinical network supporting our providers that do all the monitoring, that cut back on that signal to noise ratio. I think we got to understand what's going to motivate our patients and how to take some of the burden off of that physician, because more data is not necessarily always a good thing, right? And so how do we have that balancing act going forward?
Thanks so much, Annie. Art, any additional color that you'd like to add from your vantage point?
Yeah, no, absolutely. So, I think all of us on the line already know this, but, as much as 80% of a person's health is certainly defined by, social determinants for sure. So we partner with, a lot of our, providers in particular and payers to support their populations to self-navigate and certainly at home and is a big part of that. So we try to integrate, we call it our community-facing sites. These are their white label sites that they promote to their population so that they can help themselves. So we partner with many organizations to integrate those into patient portals, member portals. Certainly some of the platforms that are on the line here today. Anywhere that their population is accessing the organization, giving them access to the network as an additional front door so they can identify those programs and get connected to those programs. And a big part of that as well, in particular for individuals that are home-based, our home-based staff, caregivers are a big part of that care team as well. So giving all of those individuals access to the network so they can make those connections.
Thanks, Art. One of the things that I'm hearing is that, a couple of fold is that, number one, there's the great opportunity to make sure that we get all these intervening readings, but two, we have to make it meaningful, not only for the providers, but the patients as well. And then three, I think one of the common themes is that you have to have somebody on the other side looking at these in some meaningful way, because otherwise, we're not going to be able to move the needle. And it sounds like all of you have showcased some bits of that, understanding that we have to close the loop on these things. And so, that's the big takeaway that I've taken from all of your commentary, which has been great. I want to dig into something that Farzan has sort of touched on that I think is also a critical question that comes up in just, self-monitoring in general. And we can put it in the context of blood pressure or more broadly, but how do you sustain individuals in this behavior, right? So, we know in a lot of literature, we can engage them, the worried well, or we see great use of these activity monitors or these devices for the first 3 to 6 months, and then you see a decrement. And so we'd love to hear from the various folks on the panel, but I'll start with Farzan on what we've learned and where do we need to go in order to sustain these behaviors.
Absolutely. I think there's some really exciting opportunities as these remote monitoring technologies are maturing. I think we need to put a little bit more emphasis on understanding our users and context of use. Things in terms of acceptance levels of these technologies, personality traits, health beliefs, anything that contributes to intention to use them in the future and the long run, and then actual usage behavior. Again, I'll share some of these efforts in my talk tomorrow, but a very relevant emerging area in research that we're involved in is persuasive design. And I think right now we have too much emphasis and focus on functionality and usability, both of which I think are very necessary, but not sufficient to engage users in the long term. I think we're now in an era of system having to be more persuasive. And the question is, how do we design these technologies such that people want them in their life? Just like Facebook, now Meta, and Instagram, mostly social media platforms. So we use this concept very heavily in our work. If you look at, for example, fog behavior model, you get some recipes for persuasion. It talks about persuasion having, two dimensions. One is ability, which is mostly what we do nowadays to provide access to these platforms to enable self-management. But the other side of it is motivation. That dimension, I think, is mostly ignored. It's a major gap in understanding and improving motivation you mentioned.
Yeah, that's great, Farzan. And I know you mentioned the FOG sort of framework, and there's about 4 or 5 others, the chronic care model, that are all pretty similar in thinking about this arc and this journey that patients are on, and in terms of how we think about how do we motivate them to the next stage or keep them engaged. So that's really great. Rob, I know that you've got some experience here as well, and would love to hear your thoughts on insights of what you guys have learned in terms of sustaining those behaviors.
Yeah, thank you. I agree with Farzan. I mean, that understanding how to persuade them to use the technologies is critical. And for us, developing a program that helps give structure to why the patient is doing the self-monitoring at home on a frequent basis, on a daily basis, is what's important. And much like Higgy, what we've done is created a program that allows that patient, provides them an omni-channel approach, meaning you can access with a smartphone, you can access through any type of digital platform you want, but we can also access the guidance and the education through a booklet, right? So we created a program that utilizes some care plans, guided care plans, understanding blood pressure on a weekly basis. It's a 90-day program. And what we saw is that patients were engaged with it. That gave them, folks that weren't ready to use a smartphone technology, for instance, that gave them the ability to stay connected with us, with our nursing staff, with our clinical staff, and their provider through that booklet. So again, keeping that patient accountable to a certain degree was also very important between us and the patient, and then us and the physician. So it was almost like a triangle, if you can envision that, right? Because the doctor is going to talk to the patient coming into their office for a consult. They're going to say, hey, I'm going to put you on this program, and here's what I want you to do on a daily basis. By having that collaboration with their providers, meaning us, we're now tying the patient to the program and saying, here's what the provider's expectations are. And following through, getting to know that patient is really important, so that they also see that, hey, there is structure to this, and I need to follow through on what I just talked to my health, we call them health coaches as well. So what we talk to our health coaches. So all that together really provides a structured program that in the end, we provide that physician with ongoing trend lines and really kind of filter out a lot of the noise, so that they just focus on what they need to focus, which is all these patients that have maybe the critical alerts that they need to do something about.
Yeah, that's great, Rob. And I think that the pull-through thread that I hear there really is the human touch as we think about how we engage people with technology, which I think is also sometimes forgotten as we talk about technology. Art, would love your perspectives on this question.
Yeah, definitely. Mine's a little bit, different given the focus on STOH, slightly different, but I think what we've seen with some of our customers and partners, is similar to, I think what I mentioned earlier is that, they, providers are typically the trusted source for many of these individuals. So first, communication is a big, part of that, different, communication channels for different populations and, taking, cultural dynamics into place as well. So many of our customers are taking unique approaches to making them aware of, at least the work that we're doing with them, that this network exists, and then integrated into their existing workflows. So we've seen, provider organizations in particular that have integrated our platform in their patient portals, for example. They've seen a 300% uptick in usage, not only because of the communication, but also because they're integrating it into workflows that their patient population are currently, leveraging today. So, the approach that we've taken is leveraging some of those best practices that we're learning with, our providers and leveraging those with others, but also embedding the platform again across all workflows, not just one. Knowing that different patients, leverage, different platforms and different access points to the network.
So it sounds like meeting them where their preferences and choices are, to keep that sustained engagement. And then finally, Annie, who's got, there's only one way you get 300 million data points, and that's by having people come back. So I'd love to learn a little bit of the secret sauce that Higgy has employed.
Yeah, so a couple different approaches. I think the first is being in the community and making it easy from a station perspective, right? And then we partnered with the AHA as an example, where we put their clinically validated risk assessment on a station, right? So someone sitting down taking their blood pressure, they can also learn about their risk score. We're also launching our care plan with them, right? Which is coming and taking your blood pressure twice a month, learning about your personalities and your motivations, and adding on incentives, right? Around a healthy foods rewards program, right? To get them to engage from a self perspective, from a self-care perspective. And then for our really sick polychronic patients, Rob, loved what you said, because our whole the whole reason we built a large clinical network was we wanted to build a one-on-one relationship for our polychronic senior patients, right? So if you look at a year's worth of data of what we have 93% adherence to our care plans and engagement. And the reason that works is not only through more seamless device use, right? So a blood pressure cuff that doesn't require Bluetooth or Wi-Fi, but also building a one-on-one relationship, right? So when you're assigned one of our care managers, that is your person day in and day out, and we're building that relationship with that individual. Real story, we had one of our patients whose blood pressure kept spiking, and our care manager Tiffany kept saying, "Hey, what's going on? I'm taking my meds." She kept digging in further, looking at the trends of the data. Turns out he couldn't get a ride to his primary care office to pick up his hypertension meds, his new prescription. So he was taking an older version of his hypertensive meds that was a different formulary that was causing his blood pressure to spike. So when we were able to unpack that through the data we were seeing and the relationship we were building, coordinated a ride to primary care for a next day appointment, coordinated ride to pharmacy, got him back on his medication. So that's an example of when you build a relationship, right? And we know the dog's names, the grandkids' names, right? All of those things, you can actually drive adherence and responsibility. On a personal note, my dad's lost 30 pounds on the program. And the reason for that is he says, hey, when his care manager, Annie, not me, to be clear, but different Annie, is saying, hey, you stepped on the scale, I seen you gained a little weight. He's like, I'm thinking twice about eating that cake or eating that pasta. And so I think a lot of times we get so tech focused that we forget we're all humans. And we all want relationships. And when you have that accountability and you can fold in technology and start actually looking at making that data actionable, you're actually going to start to drive change.
That's really great, and some great anecdotes there, Annie. I'm going to, before we turn to some of our audience questions, I just want to pull through a thread that you raised there, Annie, and thinking about social determinants of health, which was one of the things that you brought up. And as we've gone through the pandemic, one of the things that's really been brought to the forefront is health inequities, the issue about underserved populations, rural and urban. And so as we think about technology, how are we thinking about narrowing that health equity gap and not widening it, which is right now one of the big concerns in what we've seen over the past 20 months. And so Annie, I'd love to start with you on that one, since you had mentioned that.
I think it's a real problem, and I don't know that anyone's cracked right the secret sauce, right? I think that you're seeing the pandemic, that gap's widened, and so now how do we address it? And I think if you look at some of the relationships that we're doing in the Dollar General rural communities, it's how do you build that community point of trust and then provide the resources, like the great things that Aunt Bertha, and I'm sorry, I know you rebranded. That's just how I know you guys. But like Aunt Bertha is doing to actually build a human relationship and then connect them through that. Interesting programs like with our Michigan State University is one of our clients, but they have a really awesome extension program where they have 100,000 volunteers in the community in these rural areas. So how do you start to activate some of these community members and arm them with the right technology and tools and start to educate people not only about the resources available in the community, but if you start to take control of your health, right, and layer on healthy food rewards and layer on these programs, do you actually start to drive change? But we're not going to do that unless we start hitting those rural communities.
Yeah, and I think that's really important. And since you called you out, Art, you'll have to tell us, how you guys have been, sort of thinking about, closing these gaps.
Yeah, no, absolutely. I mean, I love what Annie said there. Just to add that, totally agree with everything that was mentioned there. I think what we try to do is partner with our customers, certainly first to identify gaps. So our platform allows them to see what is their population searching for, what are they in need of, and then marry that up with programs that exist in those cities, counties, and so forth. And identify any gaps. So we often partner with customers in these rural communities that will identify a food desert. So we'll stand up food delivery programs with these partners where they're able to order food directly on the platform for their populations. And that's just one example. We often see dental care as a top search term under health in many communities. Mainly state Medicaid plans don't typically cover adult dental care. If they do, it's only emergency care. So many of our customers are seeing, pockets of their population searching for that. And they're standing up free dental care clinics once a month in these communities. So various ways that our customers are leveraging, that search activity to identify gaps and then address those in partnership with a lot of community-based organizations that we're partnered with, that they're partnered with in these communities. And then also oftentimes vendors that can supplement that support by ordering goods and services as well. So just a few ways in which, we're seeing our customers, tackle some of these difficult challenges, but certainly many others, and love to hear from the rest of the panel.
Yeah, that's a great perspective, Art. Farzan, any perspectives from your vantage point?
I completely agree with Dan, Art. I think the key ingredient there is effective and efficient stakeholder engagement and community engagement, identifying those partners, eliciting their feedback, injecting that feedback early on in the design process of these interventions. This process of user-centered design is extremely important nowadays. Establishing more of these local partnerships, conducting research with these communities, and then iteratively plan and implement and inject more feedback and monitor and evaluate and foster and sustain. I really think community engagement, stakeholder engagement is an area that's really key to all of this.
Yeah, and I think that's the consistent theme that we're hearing from everyone. And so, Rob, any insights from your vantage point that you want to add or agree with the other folks on?
No, I mean, everybody I think is spot on. I mean, there's no secret sauce to this yet, unfortunately. But one thing that Annie said that stands out is really being able to provide folks with seamless technology, right? And teaching them the importance of it. I go back to that one-on-one education, that one-on-one understanding what people are going through, what are some of the roadblocks, why don't they do this, why do they do that? Really understanding what are some of the detriments that impact them at home that perhaps you can help them with. May not help them with everything, but if there's some strategies that you can provide them as healthcare providers, then give them that guidance, that counseling, it's going to make an impact to them, right? And that tied with the connected technology that we facilitate, I think that's a good start.
That's great. Well, that's some great perspectives from all of you, and I think a topic that I think we're going to continue to see activity and best practice get integrated in how we think about delivering these solutions. And so, let me pivot to one of our audience questions, which I think is a really great question. This is from Don Casey. How are each of your technologies differentiating between BP measurements taken inaccurately and those taken in a standard fashion according to the 2017 ACC AHA guidelines and the AMA AHA target blood pressure and manufacturer assurance program? Have you thought about how a digital device could ensure that all BP measurements are taken consistently, are consistently taken accurately? Let me just start for Farzan, given where you sit at your institution in terms of having to think about how do you incorporate, a variety of devices in your digital programs. Would love to understand how you guys are thinking about this, and we'll go on down our panelists.
Absolutely. So in engineering sciences, engineering design, when we talk about sensor technology and accuracy, that has a very specific meaning. It has to meet some standards. It has to meet the status quo, the best practice. I think for BP, things like intra-arterial measurement of BP, that gold standard has to be met somehow by the sensors. If that's not the case, then at least you need to clearly make it tangible, how accurate the system is to set expectations. I'm not creating those systems myself, but I think all of that is kind of assumed and given that you need to meet those standards and you meet the gold standard. Now, I think that the second half of the question is, I think that was my response to the question. I don't think there's a second half to it.
Yeah, thanks, Farzan. Art, with your care managers and what you all do, how do you ensure there's consistency, within patients of the data that you guys or your care managers are reviewing?
Yeah, I think there's a few different ways. I think that we do that. One is we want to integrate into their existing workflows. So we do integrations in-house. So we integrate into all of their systems of records. Not only our care managers, but also community-based organizations as well. That's one piece of it, certainly. So make it easy for them to, launch and use the platform. Standardize assessments. So helping them, at least for us, since, we're helping them identify and then address social care needs, kind of make it easy for them to identify social care needs through built-in assessments. And then once the assessments are completed, it launches into recommended programs for them. So standardizing that process in their workflows to make it easy for them to identify and then address. But high level, I think those are some of the ways that we're trying to make it easier and standardize. Certainly indirect, I think, to the question, but a little bit more direct to the question you had for me.
Yeah. And I'm assuming when you standardize too, just in terms of training and teaching people how to accurately take, consistent blood pressure, is that part of the standardized process, Art, for what you guys do?
So we're not part of the blood pressure measuring process. We, as it relates to this program, we're here because health, a big part of health is related to social determinants. In addition to the blood pressure initiative, what we're doing is integrating into those workflows so that as they're supporting them with, cardiovascular, disease, they're also identifying any social needs and then addressing those so that it impacts your overall health and certainly impacts, blood pressure and cardiovascular health. Got it.
Thanks for that clarification and super helpful. Annie, it'd be great to understand you have a whole bunch of kiosks and now moving into the home. So this probably question for you and Rob is probably most apropos.
We live and breathe this every day. So our smart health stations are all FDA class cleared 2 type devices. And so we have to go through a rigorous process anyway We're in the middle of finalizing our VDL certification on those stations, as well as our blood pressure cuffs at home. So I think the more that we can all follow and rally around the same standards of what accurate blood pressure devices, cuffs, readings, and measurements are, the better. I mean, we see patients, real example, a gentleman wanted to use his own blood pressure cuff. We sent him ours from home, right? His blood pressure was much higher than the one that was 5 years old and he wasn't convinced. We sent him to one of our stations, got the same reading. And what that was kind of highlighting was the calibration of the devices. So when someone takes their reading from home, if it's an older device, if it's not following the standards of care, if they don't, if patients are not trained the proper way to take their blood pressure, right? We had a gentleman who was going for a run as part of his care plan and then taking his blood pressure and it was spiking, right? So it's not just about the devices and the standard of care, but how do you fit it into your life where you're going to get the most accurate readings over time and following same standards?
Yeah, that's great. And Rob, how have you guys tackled this issue that's emerging?
Yeah, I mean, for me, it's I'll do it from a more of a practical approach. Number one is having FDA cleared devices, absolutely. But nothing's going to be the gold standard of having a clinician take your blood pressure, right? Nothing. So I wouldn't be, you want to have devices that are FDA cleared and approved at home, but the really important factor is to ensure that the patients at home are monitoring their readings frequently, daily, right? And what that's going to cause is a trend. And as a clinician, I'm going to see these trends from this patient. And because I'm calling routinely to this patient, I'm understanding how their lifestyle, their compliance to their medication adherence, things of that nature. So I'm going to be able to see those spikes, those ups and downs that are going to be an indicator of, hey, is this device maybe not working? He's taking everything, doing everything. So I would kind of take that approach, but have a really tight kind of eye on what their trends are.
That's great.
Dr. Shah, do you want me to just quickly jump in for those that don't know what VDL is? It's a validated.
I think maybe just going into what the VDL is and maybe even just what the AMA AHA program is, it might be great, Annie. So, and I'll help chime in too as well.
You're probably more articulate than I am, so I'll do my best and then you can jump in further. But the VDL is the VDL or validated device listing criteria. It's really an additional criteria. It's really the first list of blood pressure measurement devices developed by physicians and patients to identify those blood pressure devices that have been validated for clinical accuracy. And so when I mentioned that we're doing that on our stations today, we're taking everyone from all walks of life, all genders, all different age ranges, and really validating that the blood pressure cuff and the readings and the criteria are up with the standards that were set by this organization. It's something very near and dear to the American Heart Association, right? In terms of this criteria. And so when we look at, and the reason I mentioned it was when you look at standards like this, if we can start to rally around some of these criteria and standards, that will ensure quality when we look at blood pressure readings.
Yeah, and that's really important. And Neil, you may want to chime in just as a fellow cardiologist of why this is critically important as we manage these patients, if you don't mind chiming in as well.
No, of course. I mean, having the individual take the blood pressure after sitting, not crossing their legs, not having coffee ingested previously, these are all minor factors that patients may not be aware of. And that is something that, we should be educating them about. And in addition, making sure that, they're adherent to taking it at the same time every day and they're not in any pain from any of their other sort of medical illnesses as well, because that can also skew their blood pressure readings as well.
Yeah. And this is just a joint effort between the American Medical Association and the American Heart Association, to Annie's point of more rigorous criteria so that we can ensure that, the devices are within some sort of standard error of accuracy. And so it gives confidence back to what Neil was saying in terms of as long as someone is appropriately sitting and with the appropriate posture, taking their blood pressure, we have reliability that is an accurate blood pressure and it's not due to some intrinsic variation in the device or amongst devices. And so this is an initiative that's kicked off about 2 years ago, and there's a series of studies that you have to conduct and submit on at some point in time in the year. There's 2 periods of time where you can submit as a manufacturer or as a vendor to get that seal of approval. And what that really is meant to do is give not only the patient, but also the provider confidence in the numbers that they're seeing. So hopefully that gives a little bit of context of where this space is moving and the purpose behind the AHA and the AMA in this regard. Just continuing on a little bit on this theme is there's been a lot of hype in excitement around cuffless blood pressure monitoring technologies, and I think Farzan, you talked a little bit about this, and I know for Annie and some others, this might be things that you're tracking, but where do you think we are with that? And do you think that the hype will eventually turn into reality? And how are you guys thinking about a world where there's different ways with wearables or PPG sensors to take blood pressure? And Farzan, just given your background, I'll start with you and transition to Annie as well from her vantage point.
Absolutely. So I think there's some really interesting emerging technologies in that area. We've actually seen a lot of really promising results in our research with cuffless BP devices combined with things like digital coaching and education delivered through mobile health platforms. I'll try to share some of these again tomorrow in my talk. We also published a technical report in 2019 where we documented some success story with these technologies in South Texas. I invite all of you to read that report. It's called Telemonitoring in Texas. I'd be happy to provide that if you'd like to reach out to me. But our most recent research shows a significant reduction in hospitalization rates for those who use these new technologies for remote monitoring programs in South Texas. But I think the key here is to not think about a one-size-fits-all solution. That kind of thinking always going to suffer from low utilization, low adoption rates. I think the future of BP monitoring is persuasive and personalized solutions that keeps into account many things like perceived values on all ends, stakeholder-driven type of studies to show value to provider, value to patient, understanding each person, their personality traits, their health beliefs, and their context of use. So I think that it's really exciting to see these emerging sensor technologies such as injectables, which are effortless and they provide continuous monitoring. These context-aware, artificial intelligence-enabled wearables. I think these technologies combined with more advances in human factors engineering, behavioral sciences, machine learning, that result in some really cool, disruptive, revolutionary technologies. Eventually, they enable continuous monitoring and self-management of chronic diseases.
Thank you, Farzan. And I think there's some interest in just getting a link to the paper that you just referenced in the chat. And so that's some great information. Annie, as you guys think about, all these locations that you guys have deployed kiosk and now are in the home, are you guys following these technologies, and how do you guys think about the hype versus the reality?
Yeah, I think absolutely. Of course, we're following the technology trend. Everyone is. There's a lot of cool devices coming out on the market, right? From being able to do it eventually with your smartphone to some of the watches and all of these things, but until these devices are FDA cleared devices and we can actually use them from a reimbursable or billable perspective, it's a little hard. There's some very cool stuff coming out. I think the radio frequency, some of that technology that you're seeing with the transmissions is very neat. Where I'd love to see this go is to see some of those devices get FDA cleared that are doing more than just blood pressure, right? EKG, all of these other monitoring tools. If you can embed that into kind of one action or one thing or a wearable for these patients, you're going to get a lot more accurate data and a lot more engagement. But we need to be sure that we're still looking at the motivations, right? Are people actually going to use and want to use and share all of this information? And so how do you tie all the data that we're collecting for these new sensors in a program in a way that's actually going to be used in real life.
Yeah, thanks, Annie. It's great to get your perspective on it. I know we've got about 10 minutes left in this panel, and I'm going to encourage what we have in the audience, which is great participation and attendance. Please, put your questions here in the chat so we can be sure to get to them before the top of the hour. But just keep our dialogue going. We've got three folks from industry here that are involved in care management, remote monitoring technologies. And I think it'd be just interesting for the folks in our audience just to hear a little bit about the business model. How do you partner with either payers or providers? And then two, what's the process by which you then are linked up to patients to provide your services? Might be useful for people to learn a little bit about. So we'll pivot from the clinical stuff to the art of the business. And so, Art, I'll start with you. You're on mute, Art, just in case you didn't realize.
Apologies. Yeah, thank you, and great question. So we work across many industries, so we're industry agnostic, given the work that we do. So we want to meet people in need at the various entry points, but we certainly have a huge presence in healthcare, working with over 250 plus healthcare organizations. So many of those organizations are licensing their own unique instance of Find Help, formerly known as Ampertha, to support their populations in two ways: self-navigation, as we talked about earlier, community-facing sites so that their populations have access to the network. Oftentimes, patients, members, and so forth are not comfortable sharing, social care needs with others, and/or staff don't always have all the time during a visit or an encounter to identify and address all of those social care needs. So giving them access to the network and the platform is paramount. So all of our customers, in particular in the healthcare space, are embedding these on public sites where their patients go to find providers, locations, and so forth. They embed these in patient portals like Epic MyChart and many other portals, member portals, again, anywhere where their populations are accessing the organization. Not only to empower them to self-navigate and get connected, but also, as we talked about earlier, at an aggregate level, they can see exactly what their populations are in need of. What are they searching for? And then identify any gaps, and then being able to address any of those gaps through that data and reporting analytics that the platform provides. And the second part of that is we license unique instances to support staff workflow. So any of their staff that are navigating on behalf of others, community health workers, social workers, discharge planning nurses, call center staff, care managers working with high-risk populations, you name it. We integrate it into their workflows, so it's seamless for them to, click a link, begin to search, connect, and refer, all embedded within their workflows. And then another important piece to note about, our business model is that, we're a B Corp, which means we balance profitability with social impact. So a big part of what we do is keeping our mission at the center of everything we do, connecting all people in needs to the programs that serve them. Community-based organizations are a huge part of that. They're central to that. So we support nonprofits at no cost. They claim they're listing in our network, and then they have access to free tools. And then we even integrate our platform into their existing workflows, again, at no cost. So our business model is that at the enterprise level, to providers, payers, and so forth, they license the software. It's not a seat license model; it's unlimited user model, so that their organization, their users can use the platform across all settings.
That's great, and that's a really unique model, Art. So thanks for sharing that with us, Rob. How do you engage your clients, and then similarly then the patients thereafter?
So for us, it's going to depend on our clients. So we have a typical life. We work with a variety of clients, starting with practices, individual practitioners, physician groups that are either on an ACO, participating in a value-based program, to some that are independent. So we really want to get to know what their goals are. We've got hospital systems that want to have an impact on their post-discharge process. So keeping the patient out of the hospital for the first 30 days is what's going to be critical, right? Providing a patient navigation, care management type program, that's one. For physicians that are maybe more interested in dipping into the reimbursement component of it, we've got a model for that where we can provide the turnkey services, the software, the devices, cellular devices, and the clinical health coaching program for them, and collect the minutes and manage these patients. For them, they're looking at the reimbursement program. So you take a look at that perspective. Simultaneously, we've got physician groups that, as I mentioned, are part of an ACO and have more of that value-based out metrics that are going to be important for them. So we want to work with them to help maybe address those patients that we refer to as the rising risk patients, right? That are on stage 2 hypertension, 140 to 180. We work with those patients to bring them to below the HEDIS, within the HEDIS metrics. As a result, then they can make an impact and meet their value-based metrics at the end of the year. So a variety of models out there that exist that we try to tailor for our individual clients.
That's great to understand. And then finally, Annie.
Thanks, Rob. Love to hear that. We have somewhat of a similar approach. You know, when we decided to extend what we were doing to the home, we took a really hard look at what was happening in the remote patient monitoring space. And there's a lot of tech companies with devices and EMR integration, right? And what we learned from that is there's a big provider shortage. And how do you have time to effectively manage these patients, interpret the data, and actually provide preventative care? And so we started building a purpose-built clinical infrastructure and model, right, where we have 50-state coverage, and we really look at being an extension of our providers, right? So we're never going to alter diagnosis or change the prescription. We're going to connect back into the primary care or the specialty care, but we're going to manage those patients. And so once a patient gets onboarded or referred to us, we develop the care plan with them. We overnight the devices. We do our own kitting, everything. So it looks and feels very native to that health system or that provider. We use cellular enabled devices. So all you have to do is plug in the batteries, turn the device on, then we get the data. And then you're assigned one of our dedicated care managers, right? And that's who's managing that relationship and really helping adhere to that care plan. And then when we do get an escalation or an alert, right? Because not everyone's standard is 120/80, right? We learn what their normal is, either through working with their primary care or through the data we're seeing, but we clinically vet all of that data, right? We had a woman whose grandson was jumping on a scale, right? Not helpful to set an alert to send to primary care, right? So those are examples of when we overlay our doctors on top of the nurse care managers to actually clinically vet that data and work clinician to clinician. When you do that, and then you enable that model instead of becoming cost center, right, we can help drive both fee for service and value-based care revenue, depending on who we're working with. And so we really wanted to tie a relationship and extension first, and then layer in the technology.
That's great. And I heard both you and Rob really emphasize value-based care. And that's a common theme that we're seeing in this space of no longer a fee for service or, per participant per month sort of thing, but really sort of saying, how do we actually drive to better outcomes? And so that's really exciting to see how these models are evolving. Well, we got just like a couple minutes left, and just quickly, in just a couple of sentences, I'm just going to ask, once again, our great set of panelists today, and want to first of all thank them for joining us. But I just want them all to get the last word in on what they're most excited about in this space for 2022. And I'm just going to go, reverse order, at least on my screen, and start with Farzan.
Sure. I think on the technology side, I'm really excited about injectables and more of the context of their AI-based variable kinds of technology. On the systems side, the systems perspective, I think we have a lot to do on the reimbursement side of things. I think we have a big issue there with, fluctuations in these codes and, how much of this pullback or percentage is reduced this year, that year. So there's a lot of confusion out there about guidelines and usage of these codes and how to interpret them, which is affecting, I think, this area of technology very hard. I think most information providers are getting secondhand information from attorneys. There's quite a bit of confusion going on. So I really look forward to, more straight line reimbursement to offset those high costs of labor, software, equipment, communications, so on and so forth.
That's great. It'll be exciting to see how that unfolds. Art.
Yeah, briefly, I think for us, it's continue to partner with great organizations like American Heart Association, Tupelo Life Sciences, and Higgy. How can we integrate into those workflows, give those end users access to the platform, and certainly I think continue to build upon something I mentioned earlier, which is not only giving patients and staff the ability to search, connect, and refer individuals to programs, but also the opportunity to order goods and services. So help that person at that time of need with that specific good or service that they need, and being able to order that through the platform. So continue to build upon that with a lot of our customers, payers, providers, FQHCs, and then also partners as well to fulfill a lot of those goods and services.
Great, Art. Thanks so much. Annie.
I'll be quick because I know we're at time. What's most exciting for me is the new codes, the RTM codes, but the RPM codes coming out. We're starting to see a shift for reimbursement. It's not there, but we're making progress. But most importantly, that I think all of us recognize that you got to start being proactive and bring care to the home, right? And start to consumerize healthcare. If we can tackle that and start taking a more value-based care approach where it makes sense, that's what's exciting for me, to see this trend continue to move up over the course of the next year.
Exciting. And last but not least, Rob.
Thanks, guys. Yeah, agree with Annie. Those RTM codes coming up, covering respiratory therapy, musculoskeletal therapy, they're going to be key. It's a sign of growth in our industry. It's an exciting sign for our company, Tupelo Life. One of the things that we're very interested in, I'm looking forward to 2022, is scaling our program, utilizing AI and adding more digital therapeutics to our program. So excited to continue the work that we're doing with the American Heart, the folks here at the Center for Technology and Health and Innovation, and taking this to the next level with the work and help with all the colleagues here. I think we can all help make this a better industry in terms of remote managing patients.
Thanks so much, Rob. And once again, a big thanks to our panelists, and also great thanks to the American Heart Association. We look forward to hopefully seeing everyone next year in person and see how these predictions from our panelists turn out. And so with that, want to wish everyone a great rest of AHA, and thanks again for joining us today.
Thank you, Dr. Shah. Thank you, everyone.
Thanks all.
Thank you,
Thanks, everyone.
Bye.